nobody reminded me. That was not a good thing. Y'all didn't tell me to turn it on.
I'm gonna find you a stand.
Well, isn't that the truth? We got boxes and stuff. Let's see if I want to do much more on. Okay, so you've got an idea of what beta blockers are, ending in OL, that calm the sympathetic nervous system, lower heart rate and blood pressure. Calcium channel blockers help that irritability, excitability that just keeps firing and firing, and in doing that will lower the heart rate. Then ACE inhibitors dilate the veins and decrease the blood pressure, and they end in PRIL. And then, of course, amiodarone for irregularities. AFib is the big drug. Amiodarone is so often used for AFib. But then we've got the digoxin, increases the contractibility. And that's about.
Do they use Norepinephrine very much now for?
We don't use it a lot.
That's probably a good thing. I was
Yeah.
just checking.
All right. Now, I've got a few things. Well, let's go to labs next.
What did she say about?
Oh, I think that's what I wanted to do today. Let me see if there was anything else. That was 19. We're on 19, aren't we?
Yeah, GI drugs.
Yeah, we're ready for GI drugs. Well, let's finish GI drugs. Well, you've got Tagamet. We kind of talked about that with Connie. It was kind of the granddaddy of gastric calmness or neutrality. But all these others, I'm going to tell you, I asked a physician one time, because then this new one started coming out, Prilosec and all the different kind, all the Prilosec, Protonics, all those there on the next page. And I asked a physician, just give me your favorite. And he said, there's no favorite. They're all doing the same thing, and just whatever's preference for a physician. So, you've got Tagamet, Pepcid. They've been around. They're still doing good, I think.
But you know, they have to do something different, or they
Yeah.
wouldn't have another drug.
That's right.
Because they wouldn't be able to get a patent.
That's right. That's right.
They just work in, my husband explained it to me, they work in different ways. We ought to have I think somebody else was married to a pharmacist, I am. You ought to have one of them come up and,
Yeah.
I mean, he can answer questions about medicine for days. He's worked in a hospital for like 28 years. But he did explain to me they work differently. And the reason my throat is bad a lot is I have horrible problems with my throat, and I had an endoscopy about a week ago, so now I'm still real hoarse from it. It'll go away, but right now it's still bothering me. But like I was on one of the others, and first of all, you're not supposed to stay on them. You're supposed to give yourself a break, because they've been known to cause throat cancer if you're constantly on them. And then sometimes they'll quit being effective, and I can't tell you, but like Protonics hits it in a different place than, so they just work differently. But they do the same thing. Yes,
and then bottom of 19, Pravicid. And then the next page, Reglan's an old one that's so great for nausea. And then Cytotec. And Cytotec is used in maternity, isn't it? I want to say, is it? What is? Do you not? What does Cytotec actually do? Google it, Kay. We do it at the hospital all the time to pregnant women. I'm thinking it constricts.
Does it stop heartburn?
It says it's a hormone that it can prevent stomach ulcers caused by anti-inflammatory and by insects.
It says it can treat miscarriage. Is that what you were talking about?
That's what I'm
thinking
doing.
of.
And I think it, for women, I think
Yeah.
it's constricting blood vessels. For a sore, is it saying for, it's done for overuse of NSAIDs? Is that what it said, Kay?
That it's what?
A hormone used for
Oh, yeah,
too much NSAIDs?
yes, caused by, well, stomach ulcers. It prevents stomach ulcers caused by insects.
It
So
also,
if you're on NSAIDs, you have to take that, right, to prevent it. There you go. Go ahead, let that play.
well, it also says it's used during labor, so I could see why you would
Mm-hmm.
think of it for
Yeah.
pregnant.
All right, then we've got Prilosec doing the same thing we're talking about. Zofran, great for nausea and vomiting. Protonics, same old, same old. Zantac. And Carafate, and I think I told you all on Carafate, they're giving us the slurries now, the syrup more. But, you know, it's a big pill and you had to break it and let it dissolve. You couldn't grind it because it did like sand. But pretty much now they are sending us the slurries or the, and I think I told you, I think I did, on Carafate that it covers a sore. Did I tell you all that? I think of Carafate as a, I made this up, but I think it's a good description. If I melted a candle and put wax over that sore, Carafate allows nutrition to get in. It just protects and lets it heal, but it also lets you still, you could be loaded with ulcers and still be able to get your nutrition. But like Carla said, you can't stay on it that long. Any of these, you need a break. Carafate, 6 weeks, they say, if you're not cured of what's going on with your stomach, with Carafate in 6 weeks, get off of it. Because it's for an acuteness.
Can you just get off of these?
Hmm.
Can you just stop?
Yeah, yes, and that's a
without
good
any
question.
problem?
No. All right, then let's pick it up at genital urinary next week. Is that good? All right, now let's go to lab work. And you've got your lab card, but we've also got our agenda. Let's do briefs. Go to briefs. You've got your card. Briefs also has on page what? 15. 15. All right. We're not going on all of them. We can start with them first. Acid fast bacillus, you know, is just your TB. And what are, y'all tell me, because I'm about to find out, and I'll tell you. What we're not doing, they told me at the hospital last week that there's a certain week in October that we're all gonna, you know, flu shots have to be given or you wear a mask if you're in the hospital. And they said, but we're not doing shots. We have a new thing. Do y'all know what it is?
I heard about it on the news, but
You know, we're not doing that
Just-
business.
it's
It's something mechanical that, I don't know, I've told you more than I know.
yeah.
So keep it in mind or Google or something, new testing for TB.
Yeah, I heard something on the news about it, but I honestly, I don't, I'm like you, don't know enough to tell you.
There's your arterial blood gases, and we've already beat that to death today. But do you see when it's drawn from your groin or your radial, it's put right on ice. And then, okay, keep that open and go to agenda. Go to your agenda. And I want labs on there too. Let's see. I found it, wait a minute, page 4. Really, I want page 7. Page 7 in your, Now go down to, go down to, SGOT. You see that number 8 on page 7, SGOT. Now, you've got your paper open, go back to the, keep it all open, and go to AST, the fourth one down in your briefs. Fourth one down in your briefs, do you see AST? Now, they're the same thing, so you may want to put AST under your SGOT.
So these are the same.
And then why don't you, then go back to the briefs, ALT. The ALT, and put beside it, underline in the liver, underline liver. Now, my whole point is SGOT has changed its name to AST, but not everybody still, you still see SGOT written, so it's still being used, but they're trying to get everybody just to go to AST, and it's the enzyme, normal enzyme you and I have, that shows if there's an embarrassment or impairment in the heart, liver, skeletal muscle, kidney, brain, or lungs. And that's the SGOT, and you knew that. And you knew it was an enzyme that shoots out when those organs are injured or embarrassed. Now, students taught me, it's so hard to remember, so wait a minute, ALT is only liver. It means only liver, and the students said the way they best remembered is another liver test. So it's only liver. It's a good way to remember it.
Yeah, another liver test. I like.
Which means it's just liver. And it shoots out. The body's so fascinating with these enzymes. They shoot out, trying to repair, but it shoots the level up. Now, I just wish you could keep everything open. And then, page 8 in the agenda, the very next page, at the bottom left, you see the cardiac enzymes. And it's not that you'd ever need to memorize them, but you kind of need to know which shoots out first. Which one, and you can see, I'm not reading very good, but is it CPK, isn't it? And these are all, and they're changing their names, so I just want you to realize at the different times that they shoot out. And that's why they can't give you a definitive how bad the attack is or your infarct until they get some of these enzymes back in to talk about it. Now, I'm not through. Let's go back to the briefs and go BMP, Basic Metabolic Panel. Now, keep that open and go to the very back page of the briefs. And I think we talked about it the day we started. You see your BMP. It's the electrolytes and glucose and maybe weight. They're not always the same 6 or 7. Their electrolytes are definitely in the BMP. electrolytes are always in it, but a hospital may change and put a BUN or glucose or whatever. But that's your basic metabolic panel. 1 tube of blood will fix that up. Now let's go back to page 15. Page 15 in, now you're in agenda, Delinda.
I'm in my briefs, but
Oh, yeah, okay.
I don't have it.
Very last page. Huh?
Yeah.
That's it. She really doesn't have it?
It's got some.
What number of page is it?
It doesn't have one.
It just has some little tubes on it.
Doesn't have a number. So it's really about 28. You have 27?
I have 27, 26, 27. I don't have 24. Oh, yeah. Well, let me look.
Well, we'll check it. I don't want you to leave, and we'll check them. All right, so BNP is next. And that, some people call it brain or B-type natriuretic peptide. And it's a diagnostic test for congestive heart failure greater than 100. And so if somebody's BNP is 110, you know they have heart failure. And it's just like that, barely pregnant or not. 100 is, if you're 101, it's failure. Under 100, you're good. There's your CMP, which is comprehensive. That's it. The comprehensive, and while you're looking at it, you see comprehensive metabolic. It's the 12 in 1 tube of blood. Used to be called simultaneous multiple analysis, SMA 12, chemistry 12, and now they still kind of interchange chemistry 12 with CMP. And then the intrascopic retrograde cholangiopancreatography. And it's an x-ray that checks the gallbladder and the pancreas. Fasting blood sugar. Let's see if your little card tells what fasting is. I can't remember if it tells fasting. I'm going to tell you what I want you to know.
70 to 100.
What does it say?
70 to 100, I thought.
Wait a minute. So the little card?
Fasting. Now normal, they don't want it. Well, does it have normal on here? Glucose.
This is whole blood glucose. with
How much?
Fasting 60 to 110.
60 to 110. And yeah.
It's the last one under chemistry.
They've got a different card.
Whole blood glucose fasting. That's it.
No,
60 to 110.
that one's got more. Okay.
Whole blood. If you're fasting,
Does everybody have the card with glucose?
I don't have both cards. Do we need those?
Oh,
chemistry.
it's the same. A little bit of difference, but no. All right, and then hematocrit. Now, I think I've already told you all, I want a 40. I just think that's easy to remember. A 40 for hematocrit, or packed cell volume, PCV. If the hematocrit's less than 24, a patient needs transfusion, but would never donate. And if hematocrit is less than 37, the donor cannot donate blood. 38 is when you can donate. And we're going to get more of that when we do hematology. Hematocrit is a third, hematocrit, wait just a minute, hematocrit's out. Now let's go. Hemoglobin, I don't know why it isn't on there, is a third of the hematocrit. Hemoglobin. Uh-huh. And it never fails unless you are, now here we go. You understand that hematocrit and hemoglobin are a proportion. Somebody takes a cup of blood and they push out the flow part and leave the sediment. And they look at that proportion. And normal is a third. The sediment or the hemoglobin is a third of the sediment. And that, well, so if somebody's bleeding out and you get their blood, they just had a wreck and they're at the hospital in just a short time, their hematocrit is still great because they took a cup of their blood and it's still 40. Now, half of it's out on the concrete, but the proportion is still the same. Now, it won't always be. In an hour or so, it's going to change its proportion when I fill them full of IV fluid. But initially, that hematocrit on somebody that's losing blood is going to still be good. A burn patient is a little different because look and think about it. If I've burned, I'm evaporating. So the proportion is not going to be a third. And actually, a burn person may have a high hematocrit because they've got more sediment than fluid. All right. Hemoccult, most of you know, it's AKA guaiac. Test stool and secretions for blood. Open the front of a, oh yeah, we're going to go over that later on checking occult. And TIBC is total iron binding capacity, and I don't use that, but that's what that stands for. There's troponin and CPK, and they are blood enzymes. They were on your page 8 at the bottom. That's the more elementary, just plain old troponin and CPK. Mostly heart problems, sometimes skeletal. Well, I asked a doctor, which is more definitive of an arrest or an attack. And he said, it's just when they come up. One of them comes up fast, his enzyme shoots out faster than the other one. But he said, they're both good and they're both, he said, he said, I wouldn't, there's not enough difference to even talk to you. So that's the reason I just put them together. But they will sometimes skeletal muscle, and I'll give you an example. So CPK mostly is cardiac, but it doesn't always have to be, and troponin too. If your heart has been, you don't have to wonder if it's AST or any of the other, because if the heart's involved, then troponin or CPK will shoot out, and CPK's early, if you recall, 4 hours or whatever. I went to the unit to work one night, and I think it was 4 in the morning, they called and said a patient they thought had stroked through the night and wanted to send him to the unit. And the man was in his 70s, and he had a laminectomy. And you know the laminectomy is side view. It's that little bony, this is a side view. And inside is the spinal column. And this is hanging with that little, that's the lamina. They have to remove that to get to the disc. They call it a laminectomy. I always think they ought to call it a discectomy. But they had to get rid of the lamina to get to it. And that's what he'd had. Unremarkable, everything was fine. But they wake him up at 4 in the morning, do his vital signs, and he's not responsive. I mean, he's responsive, but like a CVA. And so they wanted to admit him. He had a epidural in his back, and anesthesia, they call it anesthesia. And anesthesia said, well, it's not anesthesia that's causing this. But guess who got out of bed real quick and got it out of there before we could even before we could get him. And so I walked into his regular room, called his name, and he looked just like he'd had a stroke. He's drooling, breathing like that. I ask him to move and squeeze. He can do one side, not the other. By the time we get him all packed up to take him to the unit, I called his name and he said, "Yes, ma'am." Well, that wasn't right. And then, riding along, he took his hands and put them up behind his head. Well, that isn't right either. As soon as we got him to the unit, they did a lumbar puncture, and his spinal fluid looked great. So that didn't seem to be a problem. But I left. It was time to go home, and that particular time I worked twice. I worked the next night, and when I got there, he was sitting up watching TV, and I couldn't even put my purse down. I said, "What was it?" They said, "Well, it was really an issue. Nobody could figure it out because spinal cord looked great, the fluid, and they ran every test to see what else was out of whack, and the only one that was off was CPK. He didn't have heart issues, but CPK was the only one out, and they said that the male nursing supervisor made one statement, and they all said, yeah. The nursing supervisor said, "I wonder if he had a grand mal," and beat around in his bed, and his skeletal muscle got shot out with the enzyme. The story was that he was fine at bedtime. At midnight, he was just a little nauseated, he told them. At 2 o'clock, the nurse, quote, said he was sucking in the curtains and I didn't turn the lights on because he was sleeping so well. I hated post-surgery to do it. But he could hear him snoring and carrying on. So they didn't check on him at 2. At 4, they didn't want to go 2 more hours not checking, so they turned the lights on. He's still sucking in curtains, but in a different way. And the nursing supervisor, they all thought, why would CPK be up? And that's what they decided it was, because everything else was fine. And the same unit, I don't know what difference was, but I went in one night and I was getting a report, and there's an 18-year-old sitting up eating and watching TV. Well, in a unit, an intensive care unit now, this is a little irregular. And so I said, "What's wrong with him?" They said, "Car wreck." I said, "Well, is he okay?" Well, his CPK was up because he rolled over 18 times. They said, "See, boom, 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 boom." Isn't that fascinating? So that's why you need to keep in skeletal muscle can do it as well as the heart, but mostly it's the heart. All right, and then urine 24-hour begin when patient tell, and I think we talked about this, my pet peeve, that if I start at 4 o'clock, a 24-hour urine, I'm going to empty it the first one. It starts at 4, but I'm throwing that one away because that's urine made before. And then UUN is urine, urea, nitrogen. And 24-hour urine test done every week if a patient's on total parenteral nutrition. The high is so high in sugar and nutrition that it can burn up the nephrons. And if urea if it's not getting filtered, it'll be in the urine, won't have much. And so that'll tell you that the filter is injured.
Can I ask a question?
Uh-huh.
The CPK, what's the difference between that and the Chipotle? One's a heart attack, but...
Well, the physician said he doesn't put any difference in them. He says, the real difference is one comes up quicker than another. But as he said, he doesn't think there's that big a difference in them. All right, now that one, we're through with that page, but we're not really through with labs. Go back to the agenda, page 4 and 7, 4 to 7. page 4 to 7. And, let's do 7, page 7 first. Now, they're just categorized, but it doesn't mean you need to learn them categorized. It's just that the first 4, for instance, glucose, they have to do somewhat with diet. They're not completely, but you think of diet with like glucose. Now we know diabetes is a big deal there, but food is an issue with glucose, and you know what you want for normal. You know, I have a real cynical friend that says that making diabetics a diabetic through the years, she's a nurse, they've lowered the number led by corporate money. When I was in school, 120 was if you were
Same with
over
blood
120,
pressure now.
but now it's what?
Same with blood pressure.
Uh-huh,
Lower than
uh-huh,
yours.
yeah. And if you want to be cynical, you can say this is the reason. And see now, what is it, 110 for diabetic? Yeah. What?
Some are saying 100 now.
But
See,
none of them are above 110.
see that's, I'm telling you, and I just have to wonder if it is the mighty dollar. But anyway, you know glucose, and we're going to talk. Well, I have a whole set, not all 3 hours on diabetes, but we'll get to that more. And then we've talked cholesterol. We beat that to death, didn't we? And then the other 2, albumin is your largest protein. And then you've got the totals. Now, you notice I don't really have norms there or anything, because you don't need it. If you've been with me for the 30 minutes, you know how you can pick those up. You say, well, why'd you even give us a card if we can get them on the computer? And it's just, I think those are so few that it's good to have them to memory that are on your card. So if a physician looks at total protein and albumin, and the albumin's high but the total protein's okay, it tells you how far in the illness we are. Because if total protein and albumin are high, then we've got too much of that protein in the blood.
Say that all again.
Huh?
Say that all again.
That if albumin, which is the highest protein, is high, but total protein isn't, we're not as sick as if both are high. Because albumin's the biggest, but if the total is still okay, it hadn't.
The biggest protein or the biggest percentage? Right?
The what now?
Albumin's the biggest percentage of that, you mean?
Albumin is the largest protein in our blood.
Largest, not by percentage. And,
No.
Okay.
Now, then there's bilirubin, which you know only indicates if there's a liver issue, and breaks down fat, the enzyme that breaks down fat. And then BUN, blood urea nitrogen, not urinary. This is blood. And keep in mind, nitrogen is your largest waste product of protein. If albumin's your biggest protein, nitrogen is the biggest waste from protein. And what a good idea to check the biggest waste to get the idea if your kidneys are working or not. Now, I want kidneys on there because that's the biggest issue. When you see high BUN, you know the nephrons are not filtering sewage. It's staying in the bloodstream, and the kidneys aren't getting it out. So we know it's a kidney issue. But I want you to write in that if you've got too little BUN, it could be it could be you're not eating protein, the patient isn't eating protein to have any waste, Or we've got liver issues because what the liver breaks down protein. And if the liver isn't going to break it down, we're not going to have much waste. So you have to think about diet for low BUN or the liver for low BUN. But for high, the kidney. And see, uric acid is the kidney too. This has been divided into kind of categories. And so the kidney, uric acid is your waste byproduct of protein. And did we talk the other day on gout, the collection of gout in the earlobe or the big toe, and it's uric acid, the waste. It's a diet usually that has too much purine, and purines are from your muscle meats. I don't remember if I told you, I have a friend that eats a steak a night, grills a steak, and he has terrible gout. It's that protein, too much protein isn't great. We love protein, it's great for us.
I can't imagine eating a steak every day.
I know it. So the kidney, if you've got high uric acid, the kidney's not filtering, it's just sewerage. Just keep in mind, nitrogen, BUN, uric acid, they're just trash in your vessels. And then we've talked already on SGOT, and you see column, the third column has all the organs that we saw earlier for AST. And then we didn't mention LDH, just another great enzyme, but you see all the organs that could be involved if they got injured. Of course, heart, but just another blood enzyme. Alkaline phosphatase, I see it a lot on our floor. It's when the bone and the liver are impaired or abused. And with cancer patients, the chemo and so forth, a lot of bone issues and liver trying to break down. So alkaline phosphatase shoots out. ACE, an enzyme. Then calcium and phosphate, of course do you see the organ is the parathyroid, and we're going to talk more, or it's on your video of the endocrine system, which I'm going to talk myself more about. But you've got your thyroid gland, and then it's about the size of, it's like a butterfly, and then the parathyroids are like dried raisins, 2 on each side. I just think they're the most magical little tiny things, because blood goes through them and decides if you're low, not high. They don't care about high. Parathyroids don't care about high. But if you're low, they start pulling calcium. They shoot out parathyroid hormone to pull calcium from our teeth and our bones. I think you might underline inversely. Calcium and phosphate are inversely proportioned. If one's high, the other should be low. All right, now let's go back to page 4. And start with amylase at the top. And it's ACE, ASE, we know it's an enzyme. And it lives in the pancreas, and only comes out when the pancreas is embarrassed. And what causes that? Now, forget diabetes. It's not going to do it for diabetes. Keep in mind your pancreas has about 2 organs on it. It's got the islets of Langerhans that are producing insulin that's going to the bloodstream. But the rest of it are digestive enzymes. They don't even connect with each other. We've got islets and then ducts that go into the GI system that the digestive enzymes have a part of. Well, the idea, this is, what brings the amylase up, this enzyme? What makes it? When the pancreas has had some problems not having to do with blood sugar. The biggest one is triglycerides, fats, and sugar. I shouldn't say it, not diabetes. Sugar doesn't do it any good if it's a lot of sugar, like a drinking weekend, a binge of drinking is a lot of sugar. They're not diabetic, but it's a lot for the pancreas to work with. The whole thing about the pancreas, it doesn't like to work 24/7. And when it's asked to, it becomes inflamed. And when it does, the amylase shoots out. And there are, when I told you that we've got the islets of Langerhans for insulin, and the other 4, and we'll try to tell you what they are, but it's like lipase, trypsin, pepsin, and amylase. There are 4 digestive enzymes that go to ducts of our GI tract and help break down food. Well, why are we not doing all 4 of them? Because amylase is the biggest. So it's easier to check the one in the bloodstream that has risen. It's gone into the digestive system, but we can tell when the amylase has gone up in the bloodstream.
Amylase has gone up, does that mean all the rest of them have gone up?
Yeah, they have, but no reason to check any but the
I'm
biggest.
saying you could then automatically coordinate it if they check the one. They know the other 3 have gone.
That's right. Hmm. Yes, exactly.
Could you name those 4 again?
Lipase, trypsin,
Pepsin.
Pepsin.
And they've gotten a new name for 1 or 2 of them, but they still are under the umbrella of those enzymes. Oh, now, I think it's pancreatitis is the problem. And so the enzyme shoots out, trying to take care of the pancreas, and fat dose of constant triglycerides do the same problem. I had a friend here so there is 2 diagnostics for pancreatitis, and one is a high amylase, and the other is they call it the Buddha position. The patient finds the position that's of least pain. Apparently pancreatitis is terrible. And have you had it?
No, I've just had a friend who had it and it was awful.
Uh-huh. And they find that if they knee chest and stay on their knees, it's not fetal. I never see them lie on their side, but it is that position. They call it the Buddha position. That's diagnostic. When I worked in the emergency room in Dallas at Parkland, I think I told you, it had parts of the emergency room, and a doctor, nurse, and tech were in each place each day, and you just found where you went that day. And if I was in major medicine and they brought a gurney in and he was on his knees, I just went on and drew his amylase. And then also your assignment might be the front desk. And one day I remember I was out at the front desk, so nurses there with the clerks. And it was a slow day, and we're in the basement and just got those windows at the top. So one of the clerks got up and looked out the window, just bored. She said, "Well, we're getting a customer now." And so we said, "How bad?" "Well, they look like they're all right. They're all getting out of the car." And then she said, "Well, now wait a minute. They were walking, but they've gotten a gurney, and somebody's getting on the gurney. Well, now I'm interested." So I get up. As soon as he got on the gurney, he went into the position. So I knew he had to go to major medicine is where he'd go. I had a friend here that I went to see, and I didn't think he crawled in the bottle, but you know they get credit. I mean, they get accused of that, pancreatitis, because they really do. I didn't think he had a history. And I wasn't gonna ask. No. I
Never
knew
heard
him
that
from my
as
church,
expression.
but that doesn't mean anything. Anyway, I went up to see him. He was fleshy, very fleshy, always has been fleshy. And so I went up and I said, Mark, I went, said hi and all. I said, Mark, when did you, I said, isn't this something up here? Yeah. I said, when did you find the physician? He didn't say, what? He said, about an hour and a half. And he knew exactly what I was talking about, and he said, you just find it. You just find it. Isn't that interesting? I don't think people say that it's completely gone, but it's so much better than the pain of having it. Okay, we know ABGs. We know AFB. Oh, alpha fetoprotein. Okay, that is a blood marker, isn't it? I don't think it's an enzyme. But it shoots out with testicular or liver cancer. Now, in a minute, next page, we're going to talk about markers. We've talked about the enzymes that shoot out. So anyway, alpha fetoprotein, again, don't they do it on babies to see, I want to say mental retardation. Am I wrong? I'm not. But anyway, we can just keep it in mind. A-gap normal is 6 to 10. It's electrolytes. You don't have to know what they stand for because I don't know. It has to do with ions and the measurement between ions. And you don't need to know that. You just need to know if that isn't a 6 to 10, they've got some electrolyte problems. You notice it isn't on your card because let's just look at electrolytes. There's your ALT, AST, bleeding time, just ignore that. We're not talking about that. I'm going to forget the blood cell values. We're going to do that with hematology. Go to page 5. You already know all that. We've done blood gases, so you know that. There's your BMP, BNP. Now starts some blood markers. And blood markers indicate cancer, and they add and keep adding markers they're finding in the blood that indicate cancer. And these are some of them now, but you could probably Google and find some newer ones they're finding. But see, BRCA1 checks for breast cancer or ovarian. BRCA2, they're not on your card. You don't. It's more that if you saw it, oh yeah, that's a blood marker. Now there's your BUN, and BUN's one of those on the card. I think it's good to kind of know. I don't memorize the one on the card. To me, 6 to 26 is an easy thing to remember. You go to every place, they're all a little different, doesn't matter. Now there's some more blood markers. CA19-9, pancreatic. The trouble with that one, with pancreatic cancer is that you're having symptoms that are bad when by the time you have a symptom, it's pretty progressed. The biggest thing I hear is they go to the doctor because they're so bloated. They feel pretty good, but they're bloated. I just hadn't had this bloated stomach. And when they examine them, they probably got, no, that's ovarian, I'm sorry. Drop down to CA125, checks ovarian cancer. Often feels no pain, only bloating. And it's pretty advanced if you're that far. And so the question has come up, then why, when women get their annual GYN exam, one little tube of blood will tell us a marker? And the answer to that, because I've asked it, you imagine I have, is it's not real reliable. And if you've got cancer enormously ovarian, it's going to show CA125 high. But If you're just starting it, it may not show, so it's not reliable. Now let's go back up to pancreatic, and then breast cancer, CA2527, if you see something that looks like that, it's probably a blood marker for cancer. Calcium, it's not on your card to learn it, I don't think, because it's just in every day. Several of us came up with these because, as you all have been with me to see, we can look them up immediately. But it is good a few to really have committed to memory. Calcium's not one. Now, CEA is another blood marker. It checks it's probably the oldest. Cancer of the colon, lungs, breast, ovaries, and many false positives. It's unreliable. There's chloride. Again, we don't have you memorize that. Comprehensive metabolic panel. Creatinine is kidney. Remember, it's sewage as well. It's trash. And if it's high in the blood, it means the kidneys are not filtering our sewage. Now there's CPK. We've already been over it. And D-dimer is an interesting one to me. No number. No problem. It measures coagulation. Well, we don't really need it. We've got PTT. And so we don't need, they do it.
They still do it for peas?
They do, but the point is, if you've got a D-dimer number, that's what you don't want. If D-dimer came back with a number, or came back positive, or whatever it is, it's a coagulation issue. And PT's going to show it too. ERCP we've already done to show gallbladder and pancreas. And there's your glucose. Now H1AC checks diet compliance of diabetes, and we'll get into that again when we do our diabetes, but the red blood cell, sugar sticks to it, and I don't care, and the age of that red cell is 120 days. So you cannot start eating good 2 weeks before you go to the doctor, because it's been collecting for 4 months. And so you can be good as you can be for 2 weeks, but that red cell shows you weren't good. So and of course what we want is a 6. Now that's one, Connie, they're dropping and dropping and dropping, and I know it's got to be.
They want it, a lot of doctors say now 5.4.
Is that right?
Good
Yeah.
grief.
Yeah.
All your senators and get the commercials off TV.
Do what?
Get the drug commercials off TV. That's what's
Exactly. Yeah. All right, hemo occult we've already talked about. Okay, let's go to our next page, 6. And that's LDH. It doesn't show up good, but it's LDH. 48 hours after the ischemic event. Now, INR is important because y'all may not have remembered white clotting time. Do you remember that one? It was a clotting one. They don't use it at all now. They're trying just to go to INR, international ratio, but drop down to PT and PTT, just below you. They were trying to get rid of everything and make INR international. It hadn't worked. They've talked about that for 20 years. We do them all now, PTT, PT, and INR. But anyway, it just tells us you want it normal. If it's lower, you're clotting quicker. If it's higher, you're bleeding longer. I mean, you just have to put the good sense to it. Potassium, that's one of those we want you to remember forever. 3.4, 3.5 to 5. So little, but it interferes with the biggest muscle of all. We've got to have the right proportion of calcium to stimulate our muscle and that relationship to nerve and muscle. And if it's off a little, we go to an arrhythmia. There's LDH. That's again, isn't it? Sodium, now that's another one we like for you to remember. It's on your card. to stay kind of at 137. There's your potassium again. I don't know why they're repeated. Now, PSA is an old blood marker, too. Prostate-specific antigen. Now, that's one I like for you to remember 4. 4 is normal. But 4 to 6 can be just because you're smoking or drugs or stress. But when it starts getting in double digits, it's probably cancer of the prostate. And men apparently don't like the prostate exam. And they were thrilled when the blood test came out, the marker. But it's just not conclusive. It's good, but it's just not the answer. They need both. So there's your PTT, 20 seconds to 40 seconds, partial thromboplastin time. So if it's taken 50, it's taken too long for you to clot. PT, 10 seconds. Same thing, if it's taken 20 seconds. I don't mind that if I'm on an anticoagulant, but I do otherwise. There's SGOT, ADL, ALD, SGPT. That's only, it was the old SGPT was what it was. There's sodium, I don't know why all these repeating. It's troponin again. And urine specimen, they are really, I don't know stats. We've already talked about most. I don't know the stats, but when we open a catheter, urine catheter kit now, they have something for you to clean the perineum first before you even open your pack. And I asked somebody, and they said, hospitals are really, federal money is really debited according to infections. And the urinary tract is one of the biggest. So they're trying to do everything to keep that from happening. So they've added some little touches to catheterizations to just make it good and clean down there before you even start. Because you can tell a nurse to do that, but if she's busy and rushing, she might not. All right, and how are we? We're doing good. Now, so any question, I think that is, let's see. I think that was what I want to go over. Oh, let me look at the card. And you know, I don't have any glasses today, so it's a little hard. But did I get most of them? Did we cover most all of them? There's your ABGs, urine.
Yes.
We didn't go with specific gravity, but that's okay. Chemistry looks all right, doesn't it?
What is the normal for blood, for sugar?
Do what?
Blood and sugar, the normal is whole blood fat, 60, okay.
They call it whole blood glucose.
Okay.
That's dropping. They're just doing BG more now. Now, the last few minutes, I wanted to just talk about a couple of 3 things that are easy. Nursing process, and just make sure if anybody sits down, you are real familiar with it. Oh, yes, yes, yes. But, you know, it's assess, and then they call it your outcome or your pie in the sky, your expectation, if they didn't have that assessment you just made. So, assess, objective or outcome you want. The third part of the process is implementation. And then the fourth is evaluate. So, if, you know, kind of an aim, it's not an aim, you do it all the time. You know, we are the absolute best assessors. I say we're professional assessors because we notice things that normal people don't notice. Grocery store, cashier. I mean, you notice stuff. And But you walk in a patient's room and he calls you mother, you immediately assess, I don't want him calling me mother. I want him to call me my name. And what I need to do it, I need to tell him, I'm your nurse, here's my name, these are all the things I'm going to do to get the pie in the sky. And then, did it work? And that's your evaluation. So, that's your nursing process. We do it all the time, which is just pretty amazing that we do it all the time, analyzing them. And you do it at the grocery store. A cashier has big veins. You think, ooh, nice veins. So assess
Easy.
I would love an IV if you were a patient. And this is what I do to start that IV, and this is it. So that's the nursing process, and just keep that in mind. It was always made so hard, it seemed like, when I was in nursing school, and it's not. It's a wonderful process. Now, just keep in mind, the biggest problem, I think, when nurses, fresh out of school, or anybody that goes to a fast-paced place, the organization is the biggest thing, the time management. And working as many years as I have, I just find nothing works for me better than an hour to hour just on the back of a piece of paper. As soon as I get to work, I will put all the hours I'm going to be there. And then your patients go straight to meds, because that has to kind of be on time. Look at the meds, and I may not get 12 hours worth. I need to do at least the first 4 hours of plugging in which patients need the medicine. And I don't have to write the medicine down. Just need to say 345 med, and over here. And, every hour, plug in the hours. Then you can go to your MAR and find out what med you. But I think the hourly does the best. It's not shuffling papers and post-it notes and so forth. And it's, to me, the best way to organize yourself. It's by hours, and then you find out what hour you kind of have free that you can chart or whatever you want to do. So it's kind of a great way to organize, I think, having done it. And it's really interesting, the resistance that students have. They tell me they got their own way. And I say, but I'm telling you, I believe
Students tell you that?
Uh-huh.
They're
Oh, yeah.
stupid, how they have their own way.
And I try to tell them I'm nursing. You've never been
That's an alarm.
I have a question. We didn't mention nursing care plans while we're out there. You know, that used to be all the rate. Is that still necessary?
It's on that menu.
So it's given to us, we don't have to come up with it?
Well, they do it in education.
Okay.
Kind of, they need to deep breathe. So you would do an education thing, and that's kind of called.
Okay.
So they're doing it that way.
Okay.
Then, universal precautions. Just remember that we're doing them. When my younger years, we didn't put gloves on to clean people's mouths because it would offend them. Now everybody knows we put gloves on for most everything, except you all. I didn't know why Sarah just now. Did you wonder too? Why did she put gloves on?
I don't know, yeah, I was wondering.
She takes the patient.
Oh, she's just giving a pee. Oh man!
They do.
So you all wondered the same
I
thing.
did.
Good.
She was probably seeing it from.
Probably thought it was bad. But you know,
We're trying to be extra careful because
I try to get on to,
Oh, that's
to students who put them on unnecessarily in fields, landfills, and there's no reason. When you're hanging an antibiotic and you're going in and do your identifiers and scan, they put gloves on. I say, why have you put gloves on? Because I'm being very careful. I said, but you're not touching anything but the pump. Well, I like to be cautious. Well, that's kind of stupid. Anyway, So, and it's just filling landfills.
I think I was stupid. I used to do it just to take the call.
Do
I
what?
don't touch any, but I know when I was doing it, I would even put them on just to take their pulse. That's how
Oh,
bad
yeah.
it was. I mean,
Yeah.
It was
You
a
did?
mental thing or what.
I think you're probably right,
I mean,
students.
but then those days, the AIDS thing was going on, like a new, you know?
Well, and students,
I know.
also students think, it gives them time to think too,
Yeah.
you know, because y'all.
I was told in a nursing home that a real nurse never touches a patient. So that's why the gloves were on.
Really?
Yeah,
Say
that's
it
what,
again.
Well, because you couldn't feel anything.
when I work in the nursing home, the CNA said that a real nurse never touches a patient. She never puts her hand on a patient.
When I went to nursing
With
school
or
in
without a
the
glove.
seventies, I don't know when you went, in the
Without-
seventies,
with
we
or
were taught
without.
every patient on the floor got a back rub.
Mm-hmm.
What?
Every patient on the floor got a back rub before they went to bed if you were a floor nurse.
Back in the day.
Back in the seventies.
I could barely touch them to take their pulse.
And they all got it bad.
I wasn't.
Oh, they all got a bath.
Yeah.
Yeah.
And you know, I'm big on hygienic care because I have a plaque that a student fixed up for me that said it's better than a pill because good hygienic care is better than a pill. It'll do them more good than a
Make
pill
them
so
feel-
often.
yeah.
Clean mouth, clean perineum.
Especially clean mouth. I can't. I hate it when
And I push
they
it
get left
so.
with just.
I just think it makes you feel better than any pill. And a student came back, she graduated and went to Cincinnati, and she came back for something, and she said, I thought of you. She said, because I went to work at night, they complained about this patient all day. The patient had been grumpy and awful and horrible. As soon as report was off and I saw everybody was okay, I went to give her a bath at 9 at night. It took me an hour and a half out of my day. She never called her the rest of the night. And it was just, she was relaxed, she was clean, she was in clean sheets, her mouth was clean. It's just the best thing, and it's lost. It's been lost a lot.
A lot of patient care is just gone.
Yes, and it's just, it has not been valued enough because it does make, if you're feeling good, you do good. You're so much better. Now, let me, I've got about 5 minutes. Congestive heart failure, this is a hodgepodge stuff. You know, congestive heart failure is, first sign is dyspnea. And it's because ultimately the heart is failing and the pump is not as good. That BNP is going to be 120 and it's just not as good a pump. And so because it isn't, the first symptom is it's not pushing uphill, getting it through those lungs. And so you're dyspneic because the blood is not moving fast enough through it and with the exchange. And that's your first symptom, and you probably go to the doctor for it, and the doctor says you're starting the early, and that's your first symptom and only symptom. And so what does the doctor do? A cardiogenic drug, the digoxin's a good one, for helping that contractility, and then a diuretic to get that fluid down so the heart doesn't have to work as hard with so much fluid. And you do good. You can do good for 10 years. And then you notice your ankles are swollen. And the bad thing about heart failure is it doesn't reverse. It doesn't get stronger. It continues to deteriorate. But with our medications, and there's where medications that help us do that are great. And so if you're starting to swell fingers and hands, the pump is having a harder time bringing it up. So it's not good news if you're swelling now. And that's usually after the first one. And so you're given a little more Lasix and a little more cardiogenic drug. And that will continue for a while until briefs. Pick up your briefs. find medications. And what page is that? 16. And we may have already gone over it. Go to page. I'm trying to get to the back. Page 22. And up there you see Zeroxolin. And I may have mentioned when we went through this, did anybody have a mark by Zeroxolin? Okay. Zeroxolin enhances other diuretics. It's such a peculiar drug. If the doctor, you're swelling, you've got congestive heart failure, he has given you so much prescription for Lasix and see, that's just pulling electrolytes out and your cardiac drug, and you've got so much Lasix and you're still not really good. Instead of a couple of years, you're now coming back to me every month. Then the doctor can give them Zeroxolin. And Zeroxolin, it's a miracle, and that won't last forever, but it enhances. You can't take Zeroxolin by itself, but with a diuretic, it'll just make them a new person. It's a wonderful drug for a while, but they've got heart failure, and so it's not forever. So, now, and then, let's see, I've got about 2 minutes. Yeah. The last thing I want to say, I don't think I've said it, hydrocortisone cream, 1% you can get over the counter. And have I talked about Lamisil to y'all? Well, the 1%, it'll stop itching, I guess. But I think probably a home remedy. Vinegar is probably just as good. But a doctor told me that people call me and want the 2% because that's prescription. And he himself said, you do just as well with Lamisil. Lamisil over the counter. And so you might keep that in mind if you are one that believes in the hydrocortisone cream. The 2% is prescription, but if you just buy a Lamisil, he said that's better than the 2%. All right, let's quit it. Session 4 is over.